Joints of lower limb, introduction. The weight-bearing joints of the lower limb are more stable. Hip joint allows the same movement as the mobile shoulder joint, but the range of movement is restricted. Knee joint allows similar movements as the elbow besides the very important locking of the joint for long time standing. The leg bones do not permit the movements of supination and pronation for reasons of stability. The ankle joint also allows limited movements for the same reason. The additional movements of inversion and eversion provided at the subtalar joints are to adjust the foot to the uneven ground. Hip joint, dissection. Ligate the femoral vessels and nerve with thick thread 2 cm below the inguinal ligament. Cut them above the ligature. Cut sartorius muscle 5 cm below its origin and rectus femoris 3 cm below its origin and reflect these downwards. Detach the iliopsoas muscle from its insertion into lesser trochanter and separate the two parts. The capsule of the joint and the thickened iliofemoral ligament are now exposed. Supplement the study of the ligaments and movements on the dried bones. Type: ball and socket variety of synovial joint, multiaxial. Articular surfaces. The head of the femur articulates with the acetabulum of the hip bone to form the hip joint. The head of the femur forms more than half a sphere, and is covered with hyaline cartilage except at the fovea capitis. The acetabulum presents a horseshoe-shaped, lunate articular surface, an acetabular notch and an acetabular fossa. The lunate surface is covered with cartilage. Though the articular surfaces on the head of the femur and on the acetabulum are reciprocally curved, they are not coextensive. The hip joint is unique in having a high degree of stability as well as mobility. The sphalanophy or strength depends upon depth of the acetabulum and the narrowing of its mouth by the acetabular labrum. Tension and strength of ligaments. Strength of the surrounding muscles. Length and obliquity of the neck of the femur. Atmospheric pressure. A fairly wide range of mobility is possible because of the fact that the femur has a long neck which is narrower than the equatorial diameter of the head. Ligaments. The ligaments include the fibrous capsule, the iliofemoral ligament, the pubofemoral ligament, the ischiofemoral ligament, the ligament of the head of the femur, the acetabular labrum, and the transverse acetabular ligament. The Hrox capsule is attached on the hip bone to the acetabular labrum including the transverse acetabular ligament, and to bone above and behind the acetabulum, and on the femur to the intertrochanteric line in front, and 1 cm medial to the intertrochanteric crest behind. Anterosuperiorly, the capsule is thick and firmly attached. This part is subjected to maximum tension in the standing posture. Posteriorly, the capsule is thin and loosely attached to bone. The capsule is made up of 2 types of fibers. The outer fibers are longitudinal and the inner circular ones are called as zona orbicularis. The longitudinal fibers are best developed anterosuperiorly, where many of them are reflected along the neck of the femur to form the reticula. Blood vessels supplying the head and neck of the femur travel along these reticula. The synovial membrane lines the fibrous capsule, the intracapsular portion of the neck of the femur, both surfaces of the acetabular labrum, the transverse ligament, and fat in the acetabular fossa. It also invests the round ligament of the head of the femur. The joint cavity communicates with a bursa lying deep to the tendon of psoas major, through a circular opening in the capsule located between the pubofemoral ligament and vertical band of the iliofemoral ligament, the iliofemoral ligament I, or inverted Y-shaped ligament of Bigellum, lies anteriorly. It is one of the strongest ligaments in the body. It prevents the trunk from falling backwards in the standing posture. The ligament is triangular in shape. Its apex is attached to the lower half of the anterior inferior iliac spine, and the base to the intertrochanteric line. The upper oblique and lower vertical fibers form thick and strong bands, while the middle fibers are thin and weak. 2. The femoral ligament supports the joint inferomedially. It is also triangular in shape. Superiorly, it is attached to the iliopubic eminence, the obturator crest and the obturator membrane. Inferiorly, it merges with the anteroinferior part of the capsule and with the lower band of the iliofemoral ligament. 3. The ischiofemoral ligament is comparatively weak. It covers the joint posteriorly. Its fibers are twisted and extend from the ischium to the acetabulum. The fibers of the ligament form the zona orbicularis. Some of them are attached to the greater trochanter. 4. The ligament of the heat of the femur, round ligament, or ligamentum teres, is a flat and triangular ligament. The apex is attached to the fovea capitis, and the base to the transverse ligament and the margins of the acetabular notch. It may be very thin, or even absent. It transmits arteries to the head of the femur, from the acetabular branches of the obturator and medial circumflex femoral arteries. The acetabular larum is a fibrocartilaginous rim attached to the margins of the acetabulum. It narrows the mouth of the acetabulum. This helps in holding the head of the femur in position. 7. The transverse ligament of the acetabulum is a part of the acetabular labrum which bridges the acetabular notch. The notch is thus converted into a foramen which transmits acetabular vessels and nerves to the joint. Relations of the hip joint. Anterior relations. Tendon of the iliopsoas separated from the joint by a bursa and femoral vein, femoral artery, and femoral nerve, Fig 12.5. Posterior relations. The joint, from below upwards, is related to the following muscles: tendon of obturator externus covered by the quadratus femoris, obturator internus, and gemelli, piriformis, sciatic nerve and the gluteus maximus muscle. Superior relations. Reflected head of the rectus femoris covered by the gluteus minimus, gluteus medius, and partly by gluteus maximus. Inferior relations. Lateral fibers of the pectineus and the obturator externus. In addition there are gracilis, adductors longus, brevis, magnus and hamstring muscles. Blood supply. The hip joint is supplied by the obturator artery, 2 circumflex femorals and 2 gluteal arteries. The medial and lateral circumflex femoral arteries form an arterial circle around the capsular attachment on the neck of the femur. Retinacular arteries arise from this circle and supply the intracapsular part of the neck and the greater part of the head of the femur. A small part of the head, near the fovea capitis, is supplied by the acetabular branches of the obturator and medial circumflex femoral arteries. Nerve supply. The hip joint is supplied by the femoral nerve, through the nerve to the rectus femoris, the anterior division of the obturator nerve, the nerve to the quadratus femoris, and the superior gluteal nerve. Movements. 1. Flexion and extension occur around a transverse axis. 2. Adduction and abduction occur around an anteroposterior axis. 3. Medial and lateral rotation occur around a vertical axis. 4. Circumduction is a combination of the foregoing movements. Hip joint extension and slight abduction and medial rotation is the close packed position for the hip joint, which means the ligaments and the capsules are most taut in this position. But the surfaces are most congruent in slightly flexed, abducted, and laterally rotated position of the hip. In general, all axes pass through the center of the head of the femur, but none of them is fixed because the head is not quite spherical. Flexion is limited by contact of the thigh with the anterior abdominal wall. Similarly, adduction is limited by contact with the opposite limb. The range of the other movements is different from one another: extension 15 degrees, abduction 50 degrees, medial rotation 25 degrees, and lateral rotation 60 degrees. The movement of the hip is closely related to the position of the knee because of the presence of 2 muscles which act on both hip and knee. In the extended position of the knee, the stretch on the hamstring muscles does not allow the hip to move into its complete flexion range. Similarly, with knee completely flexed, the hip joint may not attain complete extension due to tension in the rectus femoris, which gets stretched at the hip and the knee. When the hip joints are bearing weight, the femur is fixed. But like any other joint, here also the proximal bone, i.e. pelvis, is capable of moving on the fixed distal femur. The pelvis can either move into anterior tilting, equivalent to flexion of hip, or posterior tilting, equivalent to extension of the hip. The muscles producing these movements are given in Table 12.1. Congenital dislocation is more common in the hip than in any other joint of the body. The head of the femur slips upwards onto the gluteal surface of the ilium because the upper margin of the acetabulum is developmentally deficient. This causes lurching gait, and Trendelenburg's test is positive. Perth's disease or pseudocausalgia is characterized by destruction and flattening of the head of the femur, with an increased joint space in X-ray pictures. Coxavara is a condition in which the neck shaft angle is reduced from the normal angle of about 150 degrees in a child, and 127 degrees in an adult, Fig 12.7. Dislocation of the HTTP may be posterior, more common, anterior, less common, or central, rare. The sciatic nerve may be injured in posterior dislocations. Injuries in the region of the hip joint may produce shortening of the lower limb. The length of lower limb is measured from the anterior superior iliac spine to the medial malleolus. Disease of the hip like tuberculosis, may cause referred posseat in the knee because of the common nerve supply of the two joints. Aspiration of the hip/oini can be done by passing a needle from a 0.5 cm below the anterior superior iliac spine, upwards, backwards and medially. It can also be done from the side by passing the needle from the posterior edge of the greater trochanter, upwards and medially, parallel with the neck of the femur. Hip diseases show an interesting age pattern, below 5 years congenital dislocation and tuberculosis. 5 to 10 years, Perth's disease. 10 to 20 years, Coxavara. Above 40 years, osteoarthritis. In arthritis of hip joint, the position of joint is partially flexed, abducted, and laterally rotated. Fracture of the neck of the femur may be subcapital, near the head, Fig 12.8, cervical in the middle, or basal near the trochanters. Damage to retinacular arteries causes avascular necrosis of the head. Such a damage is maximal in subcapital fractures and least in basal fractures. These fractures are common in old age, between the age of 40 and 60 years. Femur neck fracture is usually produced by trivial injuries. Trochanteric fracture may be intertrochanteric, i.e. between the trochanters, or subtrochanteric, i.e. below the trochanters. These fractures occur in strong, adult subjects, and are produced by severe, violent injuries. Shenton's line, in an X-ray picture, is a continuous curve formed by the upper border of the obturator foramen and the lower border of the neck of the femur. In fracture neck femur, line becomes abnormal. Dissection, strip the extra structures around the knee joint, leaving behind the fibrous capsule, ligaments, and parts of muscles/tendons attached to the bones/ligaments. Study the articular surfaces, articular capsule, medial and lateral collateral ligaments, oblique popliteal ligament and arcuate popliteal ligament. Features. The knee is the largest and most complex joint of the body. The complexity is the result of fusion of 3 joints in one. It is formed by fusion of the lateral femorotibial, medial femorotibial, and femoropatellar joints. Type. It is condylar synovial joint, incorporating 2 condylar joints between the condyles of the femur and tibia, and 1 saddle joint between the femur and the patella. It is also a complex joint as the cavity is divided by the menisci. Articular surfaces. The knee joint is formed by 1 condyle of the femur, 2 the patella, 3 the condyles of the tibia. The femoral condyles articulate with the tibial condyles below and behind, and with the patella in front. Ligaments. The knee joint is supported bullet in the following ligament: 1 fibrous capsule, 2 ligamentum patellae, 3 tibial collateral or medial ligament, 4 fibular collateral ligament, 6 oblique popliteal ligament, 7 arcuate popliteal ligament, 8 anterior cruciate ligament, 9 posterior cruciate ligament, 10 medial meniscus, 11 lateral meniscus, 12 transverse ligament. Hip, articuloi, capsule. The fibrous capsule is very thin, and is deficient anteriorly, where it is replaced by the quadriceps femoris, the patella, and the ligamentum patellae. Femoral adneurate, it is attached about half to 1 cm beyond the articular margins. The attachment has 3 special features. 1. Anteriorly it is deficient. 2. Posteriorly, it is attached to the intercondylar line. 3. Laterally it encloses the origin of the popliteus. Tibial attachment, it is attached about half to 1 cm beyond the articular margins. The attachment has 3 special features. L. Anteriorly, it descends along the margins of the condyles to the tibial tuberosity, where it is deficient. 2. Posteriorly, it is attached to the intercondylar ridge which limits the attachment of the posterior cruciate ligament. 3. Posterolaterally, there is a gap behind the lateral condyle for passage of the tendon of the popliteus. Some terms applied to parts of the capsule are as follows. Ligament, the fibrous capsule is attached to the periphery of the menisci. The part of the capsule between the menisci and the tibia is sometimes called the coronary ligament. Short lateral ligament, this is a cord-like thickening of the capsule deep to the fibular collateral ligament. It extends from the lateral epicondyle of femur, where it blends with the tendon of popliteus, to the medial border of the apex of the fibula. The capsular ligament is weak. It is strengthened anteriorly by the medial and lateral patellar reticula, which are extensions from the vastus medialis and lateralis, laterally by the iliotibial tract, medially by expansions from the tendons of the sartorius and semimembranosus, and posteriorly, by the oblique popliteal ligament. The capsule has 2 constant gaps. One leading into the suprapatellar. 2 another for the tendon of the popliteus. Sometimes there are gaps that communicate with the bursae deep to the medial head of the gastrocnemius, and deep to the semimembranosus. The capsule has 2 constant gaps. One leading into the suprapatellar bursa, 2 another for the exit of the tendon of the popliteus. Sometimes there are gaps that communicate with the bursae deep to the medial head of the gastrocnemius, and deep to the semimembranosus. The posterior, deep, part of the ligament is short and blends with the capsule and with the medial meniscus. It is attached to the medial condyle of the tibia above the groove for the semimembranosus. Morphologically, the tibial collateral ligament represents the degenerated tendon of the adductor magnus muscle. Fibular collateroi ligament. This ligament is strong and cord-like. It is about 5 cm long. Superiorly, it is attached to the lateral epicondyle of the femur just above the popliteal groove. Inferiorly, it is embraced by the tendon of the biceps femoris, and is attached to the head of the fibula in front of its apex. It is separated from the lateral meniscus by the tendon of the popliteus. It is free from the capsule. The inferior lateral genicular vessels and nerves separate it from the capsule. Morphologically it represents the femoral attachment of the peroneus longus. Oblique popliteal ligament. This is an expansion from the tendon of the semimembranosus. It runs upwards and laterally, blends with the posterior surface of the capsule, and is attached to the intercondylar line and lateral condyle of the femur. It is closely related to the popliteal artery, and is pierced by the middle genicular vessels and nerve, and the terminal part of the posterior division of the obturator nerve. Etquate popliteal ligament. This is a posterior expansion from the short lateral ligament. It extends backwards from the head of the fibula, arches over the tendon of the popliteus, and is attached to the posterior border of the intercondylar area of the tibia. Cruciate ligaments. These are very thick and strong fibrous bands, which act as direct bonds of union between tibia and femur, to maintain antero-posterior stability of knee joint. They are named according to the attachment on tibia. Anterior cruciate ligament begins from anterior part of intercondylar area of tibia, runs upwards, backwards and laterally and is attached to the posterior part of medial surface of lateral condyle of femur. It is taught during extension of knee, Fig 2.12. Posterior cruciate ligament begins from the posterior part of intercondylar area of tibia, runs upwards, forwards and medially and is attached to the anterior part of the lateral surface of medial condyle of femur. It is taught during flexion of the knee. These are supplied by middle genicular vessels and nerves. Menisci or semilunate or cordylcyges. The menisci are two fibrocartilaginous discs. They are shaped like crescents. They deepen the articular surfaces of the condyles of the tibia, and partially divide the joint cavity into upper and lower compartments. Flexion and extension of the knee take place in the upper compartment, whereas rotation takes place in the lower compartment. Each meniscus has the following. Two ends. The anterior and posterior ends of menisci are attached to the tibia and are referred to as anterior and posterior horns. Two borders. The outer border is thick, convex, and close to the fibrous capsule, while the inner border is thin, concave, and free. See two surfaces. The upper surface is concave for articulation with the femur. The lower surface is flat and rests on the peripheral 2/3 of the tibial condyle. The peripheral thick part is vascular. The inner part is avascular and is nourished by synovial fluid. The medial meniscus is nearly semicircular, being wider behind than in front. The posterior fibers of the anterior end are continuous with the transverse ligament. Its peripheral margin is adherent to the deep part of the tibial collateral ligament. The lateral meniscus is nearly circular. The posterior end of the meniscus is attached to the medial condyle of femur through two meniscofemoral ligaments. The tendon of the popliteus and the capsule separate this meniscus from the fibular collateral ligament. The more medial part of the tendon of the popliteus is attached to the lateral meniscus. The mobility of the posterior end of this meniscus is controlled by the popliteus and by the two meniscofemoral ligaments. Because of the attachments of the menisci to multiple structures, the motion of the menisci is limited to a great extent. Out of the two menisci, the medial meniscus has more firm attachments to the tibia. In a young person, the peripheral 25–33% of the meniscus is vascularized and is innervat. The remaining part of the meniscus receives its nutrition from the synovial fluid. Therefore, movement is important for cartilage nutrition, since movement causes diffusion of nutrients from synovial fluid to the cartilage. Functions of menisci. 1. They help in making the articular surfaces more congruent. Because of their flexibility, they can adapt their contour to the varying curvature of the different parts of the femoral condyles, as the latter glide over the tibia. 2. The menisci serve as shock absorbers. 3. They help in lubricating the joint cavity. 4. Because of their nerve supply, they also have a sensory function. They give rise to proprioceptive impulses. Transverse ligament. It connects the anterior ends of the medial and lateral menisci. Synovial membrane. Dissection. Cut through the tendon of quadriceps femoris muscle just above the knee joint. Extend this incision on either side of patella and ligamentum patelli anchored to the tibial tuberosity. Reflect patella downwards to peep into the cavity of knee joint. Note the huge infrapatellar synovial fold and pad of fat in it. Remove the fat and posterior part of fibrous capsule so that the cruciate ligaments and menisci are visualized. Features. The synovial membrane of the knee joint lines the capsule, except posteriorly where it is reflected forwards by the cruciate ligaments, forming a common covering for both the ligaments. In front, it is absent from the patella. Above the patella, it is prolonged upwards for 5 cm or more as the suprapatellar bursa. Below the patella, it covers the deep surface of the infrapatellar pad of fat, which separates it from the ligamentum patelli. A median fold, the infrapatellar synovial fold, extends backwards from the pad of fat to the intercondylar fossa of the femur. An alar fold diverges on each side from the median fold to reach the lateral edges of the patella. Bursae around the knee. As many as 12 bursae have been described around the knee, 4 anterior, 4 lateral, and 4 medial. These bursae are as follows. Anterior, 1 subcutaneous prepatellar bursa. 2 subcutaneous infrapatellar bursa. 3 deep infrapatellar bursa. 4 suprapatellar bursa. Lateral. 1a bursa deep to the lateral head of the gastrocnemius. 2a bursa between the fibular collateral ligament and the biceps femoris. 3a bursa between the fibular collateral ligament and the tendon of the popliteus. 4a bursa between the tendon of the popliteus and the lateral condyle of the tibia. Medial. 1a bursa deep to the medial head of the gastrocnemius. 2. The ons Rhine bursa is a complicated bursa which separates the tendons of the sartorius, the gracilis, and the semitendinosus from one another, from the tibia, and from the tibial collateral ligament. 3. A bursa deep to the tibial collateral ligament. 4. A bursa deep to the semimembranosus. Relations of knee joint. Anteriorly. Anterior bursae, SRC Fig 3.6, ligamentum patelli, Fig 12.12, and patellar plexus of nerves. Posteriorly. 1. At the middle, popliteal vessels, tibial nerve. 2. Postfrolae/Y, lateral head of gastrocnemius, plantaris, and common peroneal nerve. 3. Posteromedially. Medial head of gastrocnemius, semitendinosus, semimembranosus, gracilis, and popliteus at its insertion. Medially. 1. Sartorius, gracilis, and semitendinosus. 2. Great saphenous vein with saphenous nerve. 3. Semimembranosus. Laterally. Biceps femoris, and tendon of origin of popliteus. Blood supply. The knee joint is supplied by the anastomoses around it. The chief sources of blood supply are, 1. 5 genicular branches of the popliteal artery. 2. The descending genicular branch of the femoral artery. 3. The descending branch of the lateral circumflex femoral artery. 4. 2 recurrent branches of the anterior tibial artery. 5. The circumflex fibular branch of the posterior tibial artery. Nerve supply. Femoral nerve, through its branches to the vasti, especially the vastus medialis. Sciatic nerve, through the genicular branches of the tibial and common peroneal nerves. Obturator nerve, through its posterior division. Movements at the knee joint. Dissection. Clean the articular surfaces of femur, tibia, and patella on the soft specimen and on dried bones. Analyze the movements on them. Try all these movements on yourself and on your friends as well. Features. Active movements at the knee are flexion, extension, medial rotation and lateral rotation, Table 12.2. Flexion and extension are the chief movement. These take in the upper compartment of the joint above the menisci. They differ from the ordinary hinge. 1. Movement in two ways. 1. The transverse axis around which these movements take place is not fixed. During extension, the axis moves forwards and upwards, and in the reverse direction during flexion. 2. These movements are invariably accompanied by rotations or conjunct rotation. When the foot is on the ground, while standing erect, medial rotation of femur occurs during last 30 degrees of extension as in position of attention by the vastus medialis. It is called conjunct rotation. During the position of stand at ease, there is lateral rotation of femur, during initial stages of flexion, by popliteus muscle. Medial rotation of the femur occurs during the last 30 degrees of extension and lateral rotation of the femur occurs during the initial stages of flexion. When the foot is off the ground as while sitting on a chair, the tibia rotates instead of the femur, in the opposite direction. Rotatory movements at the knee are of a small range. Rotations take place around a vertical axis, and are permitted in the lower compartment of the joint, below the menisci. Rotatory movements may be combined with flexion and extension or conjunct rotations, or may occur independently in a partially flexed knee or adjunct rotations. The conjunct rotations are of value in locking and unlocking of the knee. During different phases of movements of the knee, different portions of the patella articulate with the femur. The lower pair of articular facets articulates during extension, middle pair during beginning of flexion, upper pair during mid-flexion, and the medial strip during full flexion of the knee. Locking and unlocking of the knee joint. Locking is a mechanism that allows the knee to remain in the position of full extension as in standing without much muscular effort. Locking occurs as a result of medial rotation of the femur during the last stage of extension. The anteroposterior diameter of the lateral femoral condyle is less than that of the medial condyle. As a result, when the lateral condylar articular surface is fully used up by extension, part of the medial condylar surface remains unused. At this stage the lateral condyle serves as an axis around which the medial condyle rotates backwards, i.e. medial rotation of the femur occurs, so that the remaining part of the medial condylar surface is also taken up. This movement locks the knee joint. Locking is aided by the oblique pull of ligaments during the last stages of extension. When the knee is locked, it is completely rigid and all ligaments of the joint are taut. Locking is produced by continued action of the same muscles that produce extension, i.e. the quadriceps femoris, especially the vastus medialis part. The locked knee joint can be flexed only after it is unlocked by a reversal of the medial rotation, i.e. bilateral rotation of the femur. Unlocking is brought about by the action of the popliteus muscle. Accessory or passive movements can be performed in a partially flexed knee. These movements include a wider range of rotation, antero-posterior gliding of the tibia on the femur, some adduction and abduction, some separation of the tibia from the femur. Morphology of knee joint. 1. The tibial collateral ligament is the degenerated tendon of the adductor magnus. 2. The fibular collateral ligament is the degenerated tendon of the peroneus longus. 3. Cruciate ligaments represent the collateral ligaments of the originally separate femorotibial joints. 4. Infrapatellar synovial fold indicates the lower limit of the femoropatellar joint. Osteoarthritis is an age-related cartilage degeneration of the articular surfaces. It is characterized by growth of osteophytes at the articular ends, which make movements limited and painful. However, osteoarthritis may set in at an early age also due to underlying congenital deformities or fractures around the knee joint. Structurally, the knee is a weak joint because the articular surfaces are not congruent. The tibial condyles are too small and shallow to hold the large, convex, femoral condyles in place. The femoropatellar articulation is also quite insecure because of the shallow articular surfaces, and because of the outward angulation between the long axis of the thigh and of the leg. The stability of the joint is maintained by a number of factors. The cruciate ligaments maintain antero-posterior stability. The collateral ligaments maintain side-to-side stability. The factors strengthening the capsule have been enumerated earlier. The iliotibial tract plays an important role in stabilizing the knee. Deformities of the knee. The angle between the long axis of the thigh and that of the leg may be abnormal and the one e.g. may be abnormally abducted, genivalgum or knock knee, or abnormally adducted, genivarum or bow knee. This may occur due to rickets, and posture, or as a congenital abnormality. Diseases of the knee joint may be affected by various diseases. These include osteoarthritis and various infections. Infections may be associated with collections of the fluid in the joint cavity. This gives rise to swelling above, and at the sides of the patella. The patella appears to float in the fluid. Aspiration of fluid can be done by passing a needle into the joint on either side of the patella. Bursae around the joint may get filled with fluid resulting in swellings. Injuries to the knee. Injuries to menisci strains in a slightly flexed knee, as in kicking a football, the meniscus may get separated from the capsule, or may be torn longitudinally, bucket handle tear, or transversely. The medial meniscus is more vulnerable to injury than the lateral because of its fixity to the tibial collateral ligament, and because of greater excursion during rotatory movements. The lateral meniscus is protected by the popliteus which pulls it backwards so that it is not crushed between the articular surfaces. Injuries to cruciate ligaments are also common. The anterior cruciate ligament is more commonly damaged than the posterior. It may be injured in violent hyperextension of the knee or in anterior dislocation of the tibia. The posterior ligament is injured in posterior dislocation of the tibia. The injury may vary from simple sprain to complete tear. Tear of the ligaments leads to abnormal antero-posterior mobility. Injuries to collateral ligaments are less common, and may be produced by severe abduction and adduction strains. Malalignment of patella. Ideally the patella is resting in the center of the width of the femur in a relaxed standing position. However, the patella position may be altered congenitally or due to tightness of surrounding structures which may lead to painful conditions of the patellofemoral joint. Semimembranosus bursitis is quite common. It causes a swelling in the popliteal fossa region on the posteromedial aspect. Baker's cyst is a central swelling, occurs due to osteoarthritis of knee joint. The synovial membrane protrudes through a hole in the posterior part of capsule of knee joint. Hip joint and knee joint may need to be replaced if beyond repair. In knee joint disease, vastus medialis is first to atrophy and last to recover. Dissection. Genivalgum normal genivarum Fig 12.14, deformities of the knee define the margins of both extensor retinacula, one flexor retinaculum and both peroneal retinacula. Identify the tendons enclosed in synovial sheaths, nerves, and blood vessels passing under them. Displace these structures without removing them. Clean and define the strong medial and lateral ligaments of ankle joint. Also demarcate the thin anterior and posterior parts of the capsule of the joint. Type: this is a synovial joint of the hinge variety. Articular surface. The upper articular surface is formed by I. the lower end of the tibia including the medial malleolus, 2. the lateral malleolus of the fibula, and 3. the inferior transverse tibiofibular ligament. These structures form a deep socket. The inferior articular surface is formed by articular areas on the upper, medial, and lateral aspects of the talus. Structurally, the joint is very strong. The stability of the joint is ensured by a. close interlocking of the articular surfaces. B. strong collateral ligament on the side. The tendons that cross the joint, 4 in front, and 3 on posteromedial side and 2 on posterolateral side. The depth of the superior articular socket is contributed by the downward projection of medial and lateral malleoli on the corresponding sides of talus. By the inferior transverse tibiofibular ligament that bridges across the gap between the tibia and the fibula behind the talus. The socket is provided flexibility by strong tibiofibular ligaments and by slight movements of the fibula at the superior tibiofibular joint. There are two factors, however, that tend to displace the tibia and fibula forwards over the talus. These factors are the forward pull of tendons which pass from the leg to the foot, the pull of gravity when the heel is raised. Displacement is prevented by the following factors. The talus is wedge-shaped, being wider anteriorly. The malleoli are oriented to fit this wedge. The posterior border of the lower end of tibia is prolonged downward. The presence of the intransverse tibiofibular ligament. The tibiocalcanean, posterior tibiotalar, calcaneofibular and posterior talofibular ligaments pass backwards and resist forward movement of the tibia and fibula. Ligaments. The joint is supported by a. fibrous capsule. B. the deltoid or medial ligament. C. a lateral ligament. Fibrous capsule. It surrounds the joint but is weak anteriorly and posteriorly. It is attached all around the articular margins with two exceptions. 1. Posterosuperimply it is attached to the inferior transverse tibiofibular ligament. 1. Anteroinferiorly, it is attached to the dorsum of the neck of the talus at some distance from the trochlear surface. The anterior and posterior parts of the capsule are loose and thin to allow hinge movements. On each side, however, it is supported by strong collateral ligaments. The synovial membrane lines the capsule. The joint cavity ascends for some distance between the tibia and the fibula. Deltoid or medial ligament. This is a very strong triangular ligament present on the medial side of the ankle. The ligament is divided into a superficial and a deep part. Both parts have a common attachment above to the apex and margins of the medial malleolus. The lower attachment is indicated by the name of the fibers, Fig 12.19. Superficial part. 1. Anterior fibers or tibia navicular are attached to the tuberosity of the navicular bone and to the medial margin of the spring ligament. 2. The middle fibers or tibiocalcanean exe attached to the whole length of the sustentaculum tali. 3. The posterior fibers or posterior tibiotalar are attached to the medial tubercle and to the adjoining part of the medial surface of the talus. Deep part or anterior tibiotalar is attached to the anterior part of the medial surface of the talus. The deltoid ligament is crossed by the tendons of the tibialis posterior and flexor digitorum longus. The deltoid ligament is a very strong ligament, and excessive tensile forces on the ligament result in an avulsion fracture rather than a tear of the ligament. The ligament is prone to injuries in inversion. Lateral ligament. This ligament consists of three bands as follow. 1. The anterior talofibular ligament is a flat band which passes from the anterior margin of the lateral malleolus to the neck of the talus, just in front of the fibular facet, Fig 12.20. Relations of the ankle joint. Anteriorly, from medial to lateral side, there are the tibialis anterior, the extensor hallucis longus, the anterior tibial vessels, the deep peroneal nerve, the extensor digitorum longus, and the peroneus tertius, Fig 12.17. Posteromedially, from medial to lateral side, there are the tibialis posterior, the flexor digitorum longus, the posterior tibial vessels, the tibial nerve, the flexor hallucis longus. Posterolaterally, the peroneus longus, and the peroneus brevis. Movements. Active movements are dorsiflexion and plantar flexion. 1. In dorsiflexion, the forefoot is raised, and the angle between the front of the leg and the dorsum of the foot is diminished. It is a close pack position with maximum congruence of the joint surfaces. The wider anterior trochlear surface of the talus fits into lower end of narrow posterior part of the lower end of tibia. There are no chances of dislocation in dorsiflexion. 2. In plantarflexion, the forefoot is depressed, and the angle between the leg and the foot is increased. The narrow posterior part of trochlear surface of talus loosely fits into the wide anterior part of the lower end of tibia. High heels cause plantar flexion of ankle joint and its dislocations, see Fig 9.10. Blood supply. From anterior tibial, posterior tibial, and peroneal arteries. Nerve supply. From deep peroneal and tibial nerves. Clinical anatomy. The sprains of the ankle are almost always abduction sprains of the subtalar joints, although anew fibers of the deltoid ligament are also torn. True sprains of the ankle joint are caused by forced plantar flexion, which leads to tearing of the anterior fibers of the capsule. The joint is unstable during plantar flexion. Dislocations of the ankle are rare because joint is very stable due to the presence of deep tibiofibular socket. Whenever dislocation occurs, it is accompanied by fracture of one of the malleoli. Acute sprains of lateral ankle occur when the foot is plantar flexed and excessively inverted. The lateral ligaments of ankle joint are torn, giving rise to pain and swelling. Acute sprains of medial ankle occur in excessive eversion, leading to tear of strong deltoid ligament. These cases are less common. The optimal position of the ankle to avoid ankylosis is one of slight plantar flexion. For injections into the ankle joint, the needle is introduced between tendons of extensor hallucis longus and tibialis anterior with the ankle partially plantar flexed. During walking, the plantar flexors raise the heel from the ground. When the limb is moved forwards, the dorsiflexors help the foot in clearing the ground. The value of the ankle joint resides in this hinge action, in this to and fro movement of the joint during walking. Tibiofibular joints. Dissection. Superior tibiofibular joint. Remove the muscles around the superior tibiofibular joint. Define the tendon of popliteus muscle on its posterior surface. Open the joint. Middle tibiofibular joint. Remove the muscles from anterior and posterior surface of the interosseous membrane and define its surfaces. Inferior tibiofibular joint. Define the attachments of anterior and posterior tibiofibular ligaments including inferior transverse tibiofibular ligament. Divide these to expose the strong interosseous tibiofibular ligament. Use dry bones and articulated foot to understand the attachments of the ligaments. The tibia and fibula articulate at three joints, the superior, middle and inferior tibiofibular joints. Superior tibiofibular joint. This is a small synovial joint of the plane variety. It is formed by articulation of small, rounded, flat facets present on the head of the fibula, and on the lateral condyle of the tibia. The joint permits slight gliding or rotatory movements that help in adjustment of the lateral malleolus during movements at the ankle joint. The bones are united by a fibrous capsule which is strengthened by anterior and posterior ligaments. These ligaments are directed forwards and laterally. The cavity of the joint may communicate with the knee joint through the popliteal bursa. The joint is supplied by the nerve to the popliteus, and by the recurrent geniculate nerve. Middle tibiofibular joint. This is a fibrous joint formed by the interosseous membrane connecting the shafts of the tibia and the fibula. The interosseous membrane is attached to the interosseous borders of the two bones. Its fibers are directed downwards and laterally. It is wide above and narrow below where it is continuous with the interosseous ligament of the inferior tibiofibular joint. It presents a large opening at the upper end for the passage of the anterior tibial vessels, and a much smaller opening near its lower end for the passage of the perforating branch of the peroneal artery. Relations. Anteriorly. Tibialis anterior, extensor digitorum longus, anterior tibial vessels, deep peroneal nerve extensor hallucis longus and peroneus tertius. Posteriorly. Tibialis posterior and flexor hallucis longus. Nerve supply. Nerve to popliteus. Functions. 1. The membrane provides additional surface for attachment of muscles. 2. Binds the tibia and the fibula. 3. Resists the downward pull exerted on the fibula by the powerful muscles attached to the bone. Note that the biceps femoris is the only muscle that pulls the fibula upwards. Inferior tibiofibular joint. This is a syndesmosis uniting the lower ends of the tibia and the fibula. The bony surfaces are connected by a very strong interosseous ligament, which forms the chief bond of union between the lower ends of these bones. The interosseous ligament is concealed both in front and behind by the anterior and posterior tibiofibular ligaments, whose fibers are directed downwards and laterally. The posterior tibiofibular ligament is stronger than the anterior. Its lower and deep portion forms the inferior transverse tibiofibular ligament, which is a strong thick band of yellowish fibers passing transversely from the upper part of the malleolar fossa of the fibula to the posterior border of the articular surface of the tibia, reaching up to the medial malleolus. Blood supply. Perforating branch of the peroneal artery, and the malleolar branches of the anterior and posterior tibial arteries. Nerve supply. Deep peroneal, tibial and saphenous nerves. The joint permits slight movements, so that the lateral malleolus can rotate laterally during dorsiflexion of the ankle. Clinical anatomy. The inferior tibiofibular joint is strong. The strength of the ligaments uniting the lower ends of the tibia and fibula is an important factor in maintaining the integrity of the ankle joint. The slight movements of the lateral malleolus taking place at this joint provide suppleness to the ankle joint. Joints of the foot dissection. Remove all the tendons, muscles from both dorsal and plantar aspects of the tarsal, metatarsal, and phalanges. Define, identify the ligaments joining the various bones. Ligaments are stronger on the plantar aspect than the dorsal aspect. Subtalar joint. Divide the ligaments which unite the talus and calcaneus together at the talocalcanean, navicular joints. Study these joints carefully to understand the movements of inversion and eversion. On the lateral side of foot, define the attachments of long plantar ligament. Reflect this ligament from its proximal attachment to see the deeper plantar calcaneocuboid ligament. Classification. The joints of the foot are numerous. They can be classified as intertarsal, tarsometatarsal, intermetatarsal, metatarsophalangeal, interphalangeal. The main intertarsal joints are the subtalar or talocalcanean joint, the talocalcaneonavicular joint and the calcaneocuboid joint. Smaller intertarsal joints include the cuneonavicular, cuboidinavicular, intercuneiform and cuneocuboid joints. The movements permitted at these joints are as follows. The intertarsal, tarsometatarsal and intermetatarsal joints permit gliding and rotatory movements, which jointly bring about inversion, eversion, of the foot. Pronation is a component of eversion, while supination is a component of inversion. The metatarsophalangeal joints permit flexion, extension, adduction, and abduction of the toes. The interphalangeal joints of hinge variety permit flexion and extension of the distal phalanges. A brief description of the relevant joints is given below. Subtalar or talocalcanean joint. There are three joints, posterior, anterior and medial between the talus and the calcaneum. The posterior joint is named the talocalcanean or subtalar joint, where concave undersurface of body of talus articulates with convex posterior facet of the calcaneum. The anterior joints are parts of the talocalcaneo-navicular joint. On the anterior and medial side of undersurface of head of talus, the surfaces are convex and articulate with concave articulating surfaces of calcaneum. Since the three joints form a single functional unit, clinicians often include these joints under the term subtalar joint. However, the sinus tarsi separates the posterior articulations from the anterior and medial articulations. The greater part of the talocalcaneo-navicular joint lies in front of the head of the talus and not below it. Talocalcanean joint. The talocalcanean joint is a plain synovial joint between the concave facet on the inferior surface of the body of the talus and the convex facet on the middle one-third of the superior surface of the calcaneum. The bones are connected by a fibrous capsule. The lateral and medial talocalcanean ligaments, the interosseous talocalcanean ligament, and the cervical ligament, the interosseous talocalcanean ligaments, is thick and very strong. It is the chief bond of union between the talus and the calcaneum. It occupies the sinus tarsi, and separates the talocalcanean joint from the talocalcaneo-navicular joint. It becomes taut in eversion, and limits this movement. The cervical ligament is placed lateral to the sinus tarsi. It passes upwards and medially, and is attached above to a tubercle on the inferolateral aspect of the neck of the talus. It becomes taut in inversion, and limits this movement. In addition to the interosseous and cervical ligament, the collateral ligaments of the ankle joint also provide stability to the talocalcanean joint. Movements. The joint participates in the movements of inversion and eversion of the foot described at the end of chapter. Talocalcaneo-navicular joint. The joint has some of the features of a ball and socket joint. The head of the talus fits into a socket formed partly by the navicular bone, and partly by the calcaneum. Two ligaments also take part in forming the socket. These are the spring ligament medially, and the medial limb of the bifurcate ligament laterally. The bones taking part in forming the joint are connected by a fibrous capsule. The capsule is supported posteriorly by the interosseous talocalcanean ligament, dorsally by the dorsal talonavicular ligament, ventromedially by the spring ligament, and laterally by the medial limb of the bifurcate ligament. The spring ligament is described below. The bifurcate ligament is described with the calcaneo-cuboid joint. Movements. The movements permitted at this joint are those of inversion and eversion. They are described below. The spring ligament or plantar calcaneo-navicular ligament is powerful. It is attached posteriorly to the anterior margin of the sustentaculum tali, and anteriorly to the plantar surface of the navicular bone between its tuberosity and articular margin. The head of the talus rests directly on the upper surface of the ligament, which is covered by fibrocartilage. The plantar surface of the ligament is supported by the tendon of tibialis posterior medially, and by the tendons of flexor hallucis longus and flexor digitorum longus, laterally. The spring ligament is the most important ligament for maintaining the medial longitudinal arch of the foot. Calcaneo-cuboid joint. This is a saddle joint. The opposed articular surfaces of the calcaneum and the cuboid are concavo-convex. On account of the shape of articular surfaces, medial movement of the forefoot is accompanied by its lateral rotation and adduction or inversion. Lateral movement of the forefoot is accompanied by medial rotation and abduction or eversion. The bones are connected by 1. A fibrous capsule. 2. The lateral limb of the bifurcate ligament. 3. The long plantar ligament. 4. The short plantar ligament. The bifurcate ligament is Y-shaped. Its stem is attached to the anterolateral part of the sulcus calcanei, the medial limb or calcaneo-navicular ligament, to the dorsolateral surface of the navicular bone, and the lateral limb or calcaneo-cuboid ligament, to the dorsomedial surface of the cuboid bone. Thus each limb of the ligament strengthens a separate joint. The long plantar ligament is a long and strong ligament whose importance in maintaining the arches of foot is surpassed only by the spring ligament. It is attached posteriorly to the plantar surface of the calcaneum, and anteriorly to the lips of the groove on the cuboid bone, and to the bases of the middle three metatarsals. It converts the groove on the plantar surface of the cuboid into a tunnel for the tendon of the peroneus longus. Morphologically, it represents the divorced tendon of the gastrocnemius. The short plantar ligament or plantar calcaneocuboid ligament lies deep to the long plantar ligament. It is broad and strong ligament extending from the anterior tubercle of the calcaneum to the plantar surface of the cuboid, behind its ridge. Transverse tarsal or mid-tarsal joint. This includes the calcaneocuboid and the talonavicular joints. The talonavicular joint is a part of the talocalcaneonavicular joint, and hence the transverse tarsal joint may be said to be made up of only 1½ joints. These joints are grouped together only by virtue of being placed in nearly the same transverse plane. In any case, the two joints do not form a functional unit. They have different axes of movements. It demarcates the forefoot from the hind foot. Its movements help in inversion and eversion of the foot. Inversion and eversion of the foot. Inversion is a movement in which the medial border of the foot is elevated, so that the sole faces medially. Eversion is a movement in which the lateral border of the foot is elevated, so that the sole faces laterally. These movements can be performed voluntarily only when the foot is off the ground. When the foot is on the ground, these movements help to adjust the foot to uneven ground. In inversion and eversion, the entire part of the foot below the talus moves together. The movement takes place mainly at the subtalar and talocalcaneonavicular joints and partly at the transverse tarsal joints. The calcaneum and the navicular bone move medially or laterally round the talus, carrying the forefoot with them. Inversion is accompanied by flexion of the foot and adduction of the forefoot. Eversion is accompanied by dorsiflexion of the foot and abduction of the forefoot. Joinels toking port, subtalar, talocalcanean. 1 talocalcaneonavicular. Accessory, transverse tarsal, which includes calcaneocuboid and talonavicular joints axis of movements. Inversion and eversion take place around an oblique axis which runs forwards, upwards, and medially, passing from the back of the calcaneum, through the sinus tarsi, to emerge at the superomedial aspect of the neck of the talus. The obliquity of the axis partly accounts for adduction, abduction, plantar flexion, and dorsiflexion, which are associated with these movements. Range of movements. 1. Inversion is much more free than eversion. 2. The range of movements is appreciably increased in plantar flexion of the foot because, in this position, the narrow posterior part of the trochlear surface of the talus occupies the tibiofibular socket. In this position, slight side-to-side movements of the talus are permitted. Muscles producing movements. Inversion is produced by the actions of the tibialis anterior and the tibialis posterior, helped by the flexor hallucis longus and the flexor digitorum longus. Mechanism. During inversion, the forepart of foot is adducted at mid-tarsal joint, followed by lateral rotation of foot at subtalar joint. During eversion, the reverse of this occurs. Pronation and supination of the foot. These are really components of the movements of inversion and eversion. In pronation and supination, the forefoot, i.e. the distal part of the tarsus and metatarsus, moves on the calcaneum and talus. The medial border or the forefoot is elevated in supination, which is thus a part of inversion, while the reverse occurs in pronation, and the eversion. These movements take place chiefly at the transverse tarsal joint and partly at smaller intertarsal, tarsometatarsal and intermetatarsal joints. There are differences when supination and pronation occur in weight-bearing and non-weight-bearing situations. In weight-bearing supination and pronation, the calcaneum is not free to move in all directions, and the motions are thus completed by compensatory movements of the talus. Limiting factors. Inversion is limited by 1. Tensor of peronei. Tension of cervical ligament. Eversion is limited by 1. Tension of tibialis anterior. 2. Tension of tibialis posterior. 2. Tension of deltoid ligament. Functional significance. Inversion and eversion greatly help the foot in adjusting to uneven and slippery ground. When feet are supporting the body weight, these movements occur in a modified form called supination and pronation, which are forced on the foot by the body weight. Smaller joints of forefoot. Dissection. Cut across the cuneo-cuboid, cuneo-navicular, and intercuneiform joints to expose the articulating surfaces. With a strong knife, cut through tarsometatarsal and intermetatarsal joints. Try to separate the bones to see interosseous ligaments. Detach abductor hallosus, phylloxer hallosus brevis, adductor hallosus from the sesamoid bones of the big toe. Cut the deep transverse metatarsal ligaments on each side of the third toe. Now the tendons of dorsal and plantar interossei can be seen till their insertion. Identify the distal attachments of the lumbrical muscles as well. Identify the extensor expansion on the dorsum of digits and see its continuity with the collateral ligaments. Study these joints from the text provided. Features. These are plain joints between the navicular, the cuneiform, the cuboid and the metatarsal bones. They permit small gliding movements, which allow elevation and depression of the heads of the metatarsals, as well as pronation and supination of the foot. Joint cavities of foot. There are only 6 joint cavities in the proximal part of the foot. These are intertarsal, tarsometatarsal, and intermetatarsal joints, Fig 12.24. The cavities are, 1 talocalcean, 3 talocalcaneo-navicular, 4 calcaneo-cuboid, 1 first cuneo-metatarsal, 2 cubometatarsal, 1 cuneo-navicular with extensions, i.e. navicular with 3 cuneiforms and second and third cuneo-metatarsal joints. Metatarsophylongeal and interphalangeal joints. The structure of these joints is similar to the corresponding joints of the hand, with 2 exceptions. 1. The deep transverse ligaments of the foot connect all the 5 toes instead of only 4 fingers in the hand. 2. The toes are adducted and abducted with reference to the second toe and not the third finger as in the hand. Gait. Walking gait is a motion which carries the body forwards. There are 2 phases, swing and stance. Swing phase. 1. Flexion of hip, flexion of knee and plantar flexion of ankle. 2. Flexion of hip, extension of knee and dorsiflexion of ankle. Stance phase. 1. Flexion of hip, extension of knee and foot on the ground. 2. Extension of hip, extension of the knee and foot on the ground. Clinical anatomy. Females wearing high heels, more than 5 centimeters, put stress on their back and lower limbs. The spine is pushed forwards, knees are excessively bent, resulting in too much pull on some muscles and ligaments. High heels result in shift in position of center of gravity. The problems caused by high heels are fashionable diseases. The sprains of the medial and lateral ligaments of ankle joint are almost always due to high heels. Joints of the foot lead to various deformities like mallet toe, hammer toe, and claw toe. Arthroscopy. One can look into the joint by special instruments called the arthroscope. For hip joint, the instrument is introduced 4 cm lateral to the femoral pulse and 4 cm below inguinal ligament. For knee joint, the arthroscope is introduced from the front of the semi-flexed knee joint. For ankle joint, the instrument is introduced medial to the tendon of tibialis anterior muscle. One needs to be careful of the great saphenous vein. Halplex unjagus, due to ill-fitting shoes, great toe gets pushed laterally, even dislocating the sesamoid bone. Head of first metatarsal points medially and adventitious bursa develops there. Toes may be deformed at their joints resulting in claw toe. Fractured toe is bandaged with the adjacent toe, this is called buddy splint, Fig 12.27. Morphologic significance. In intrauterine life and early infancy, the soles of the feet are turned inwards, so that they face each other's. As growth proceeds, the feet are gradually everted to allow a plantigrade posture. Such eversion does not occur in apes. Mnemonics of locking and unlocking. LMFTTE. Locking is medial rotation of femur on tibia at terminal stages of extension when foot is on the ground. ULFIT. Unlocking is lateral rotation of femur on tibia at initial stages of flexion when foot in on the ground. LLTFTE. Locking is lateral rotation of tibia on femur at terminal stages of extension when foot in off the ground. UMTFIF. Unlocking is medial rotation of tibia on femur at initial stages of flexion when foot is off the ground. Knee joint is the most complicated joint. Flexion and extension are allowed in the upper compartment of knee joint while rotation is permitted in the lower or meniscotibial compartment. Inversion and eversion occur at talocalcaneonavicular joint, assisted by movements at transverse tarsal joints, i.e. talonavicular and calcaneocuboid joints. Locking muscle is vastus medialis, part of quadriceps femoris. Unlocking muscle is popliteus. Tendon of peroneus longus crosses the sole from lateral to medial side. Inferior tibiofibular joint is a syndesmosis type of joint, i.e. joint formed by ligaments only. Fibula does not take part in knee joint, but participates in the formation of ankle joint. Talus has no muscular attachment. Tendon of flexor hallucis longus courses between the two tubercles of its posterior process. The big toe carries double the weight to the ground than any of other four toes. Mallet toe, hammer toe, claw toe. Fig 12.26, deformities of toes.